Now, after hypertension, we come to dyslipidemia or hyperlipidemia as transplant recipients. And this issue will be presented by Professor hasaballa, Professor of Medicine and Nephrology at Cairo University. Please, Dr. Maya.
Bismillahirrahmanirrahim. I'd like to thank you all for coming. I'd like to thank Professor Dr. Fahed and Professor Dr. Amr Hussein. And I know it's difficult talking after Professor Omar Khashab. But anyways, the topic today is on hyperlipidemia and transplant recipients and management guidelines. And I agree very much with Professor Omar Khashab how much the guidelines are changing. I'm going to be discussing today, because of course transplant patients are CKD patients originally, so I'll be discussing the KDIGO guidelines that have been released just this year, a few months ago, and I'm going to be addressing CKD patients. I find it very difficult not to consider the CKD patients as well, because they're very much related to the transplant patients, but we'll concentrate on the transplant population. And just to be speaking on standing in common grounds, we say we recommend when, and this is for the strength of recommendation, it's level 1 when we mean to say we recommend, and it's level 2 when we just say we suggest, so this is weaker, and we say it's not graded when it's left to common sense. And considering the strength of the quality of the supporting evidence, it's graded from A to D, and it's A when it's high, when we are confident that the true effect is close to that of the estimate of the effect, and the least is D, which is very low, when the effect is uncertain. And I'd like to discuss with you some general considerations first, and you've been hearing all the time for the last 2 days that patients with CKD have a high cardiovascular mortality, and this is true, and it's more than 40%, and this is much, much higher when you compare it to other causes of mortality. And you know very well that LDL cholesterol is strongly and independently associated with the risk of atherosclerotic events in the general population. What about our CKD population? You do know that it does have an impact on the lipid profile. In nephrotic syndrome, you have an increase in LDL cholesterol and in triglycerides. In non-nephrotic CKD stages 2 to 4, you have a normal LDL, but you have elevated triglycerides. In hemodialysis, you have an addition, high LDL in 56% of the cases, which increases even further, with peritoneal dialysis mounting to 73%. And in transplant population, you have an increase in LDL cholesterol, especially that they're using drugs like corticosteroids, cyclosporine, and sirolimus. So dyslipidemia is common in patients with CKD, but LDL cholesterol does not reliably discriminate between those at low or high risk of cardiovascular events. And why is that? If you look here, this shows you the relation between the hazard ratio for myocardial infarction and the LDL cholesterol level, and you can see, and this is different degrees of GFR. So if you look here, you will find that at the GFR of 90 milliliters per minute, the relation is more steep, and meaning that with an increase in LDL cholesterol, you have a higher increase in the risk for myocardial infarction, and this is decreased as the GFR declines. This means that in CKD patients, as GFR declines, the magnitude of the excess risk associated with increased LDL cholesterol decreases. And you all know, of course, about the fact that CKD patients, besides the traditional risk factors, they have non-traditional risk factors for cardiovascular risk. So therefore, higher cardiovascular risk and not elevated LDL cholesterol is now the primary indication to initiate or adjust a lipid-lowering treatment. And this is very important. And there are 3 potential determinants for the decision to prescribe lipid-lowering treatment. The first is the baseline coronary risk, which is the 10-year incidence of coronary death or non-fatal myocardial infarction. It is estimated to be 20 per 1,000 patient years in those with prior myocardial infarction. This, of course, necessitates treatment. And it is around 10 to 20 per 1,000 patient years in patients with diabetes and prior stroke, and this again requires treatment, but when it's 10 per 1,000 patient years, no treatment is indicated. And the case fatality rate following myocardial infarction is increased among patients with CKD as compared to those with normal kidney functions, but this knowledge in itself is not enough. We have to have the evidence that a lipid-lowering treatment is beneficial. In fact, current guidelines sensitize all of the available evidence, but it's largely dependent on few randomized controlled trials that were done specifically in our CKD population. Only the ALERT study was carried out in transplant populations, and the CKD patients that have been found in the statin trials on the general population. And the questions that are addressed by guidelines include how and when to assess lipid status, how and when to prescribe lipid-lowering treatment in the target population. So I'm going to be speaking about the recommendation statement now, and they are divided into three. First, assessment of lipid status in adults with CKD, and then pharmacological cholesterol-lowering treatment in adults, and triglyceride-lowering treatment in adults. So starting first with the assessment of the lipid status in adults with CKD, the first statement says that in adults with newly identified CKD, including those treated with chronic dialysis or kidney transplantation, we recommend evaluation with their lipid profile, including total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides, and this is graded as 1C. In fact, there is no direct evidence indicating that measurement of lipid status will improve clinical outcome in this patient population. But we have to assess it not just because it's minimally invasive or because it's inexpensive, but because it establishes a diagnosis of severe hypercholesterolemia and or hypertriglyceridemia and potentially rule out a remediable cause if present. So it has the potential of improving the patient health in those with secondary causes like nephrotic syndrome, hypothyroidism, diabetes, excessive alcohol consumption, and liver disease, and a big list of medications. Now, the second statement says that in adults with CKD, including those treated with chronic dialysis and or kidney transplantation, follow-up measurement of lipid levels is not required for the majority of cases. So it's just not required. And in fact, there is no evidence to say that repeated measurements of lipid levels will have an impact on outcome. Now, this is a compilation of studies that have been carried out in the general population, and it just tells you in each of these studies that the lower the level of LDL cholesterol, the better or the less will be the cardiovascular events. And this led to the consensus of treatment to target, and this necessitates frequent measurements. But treat to target is not anymore indicated in our patient population. First, because of lack of data to support this approach in our target population, and because of the substantial within-person variability in LDL cholesterol measurements, and because of the potential for medication-related toxicity. So we only do that if the results would alter the management, like for assessment of adherence to statins, or when you have a change in the RRT modality, or when you have a concern about the presence of a new secondary cause, or when you want to assess the cardiovascular risk in a patient who's less than 50 years and not currently receiving statins. Now I'm going to speak quickly about the pharmacological cholesterol-lowering treatment, and this is the second part, and we'll concentrate first on those before dialysis. And the statement says that in adults aged more than 50 years with an eGFR less than 60 milliliters per minute and not treated with chronic dialysis or kidney transplantation, we recommend treatment with statin or statin-ezetimibe combination, and this is graded as 1A. And in adults aged 50 years or above with CKD, GFR 60 milliliters per minute or more, that's to say G1 to G2, we recommend treatment with statin, but this is graded as 1B. Now, if you look here, you will find that patients with CKD and no diabetes, they have a higher, this is the risk, this is the incidence risk for coronary death or non-fatal myocardial infarction. So you can see here that those patients who are CKD without diabetes have a higher risk exceeding 10 than patients with diabetes without myocardial infarction. But the risk is also age-related. So if you look at those patients who are more than 50 years, you will find that CKD patients without diabetes or myocardial infarction, as well as CKD patients with diabetes and CKD patients with myocardial infarction, all those patients have a risk which is higher than 10. So this means that all patients who are above 50 years should receive statins. And this also, this just tells you the same thing, but even when you divide it into stages of GFR, this applies to GFR stage 3 to 4 to G4, and also stages G1 and G2, and it's even, and the risk is higher in those patients with lower kidney functions. Whereas if you look at those patients who are younger than 50 years, you will find that CKD patients with no diabetes and no prior myocardial infarction, they have a risk which is less than 10. Whereas if you combine any of those factors with CKD, the risk goes higher than 10. And this made the third statement, which says that in adults aged 18 to 49 years with CKD but not treated with chronic dialysis or kidney transplantation, we suggest statin treatment in people with one or more of the following, and this is graded as 2A. We suggest, not we recommend. If they have known coronary disease, diabetes mellitus, prior ischemic stroke, estimated 10-year incidence of coronary death or non-fatal myocardial infarction of more than 10%. And what's the evidence for that? Well, this is a very big study, which is a SHARP study, comprising more than 9,000 participants, aged more than 40 years. 33% of them were on regular dialysis treatment and 23% were diabetics. And they were randomized to receive placebo or ezetimibe simvastatin 20 milligram combination, and were followed up for 5 years. And the results were a significant 17% reduction in the relative hazard of the primary outcome of major cardiovascular events compared to placebo. But they did not reduce the risk of progression to end-stage renal disease requiring renal replacement therapy. Remember that we have some studies indicating that, like the TNT study, for instance, indicating that correction of or treatment of dyslipidemia has a good impact on progression or the renal outcome, but this was not proved in the recent researches that you see here. And also did not significantly reduce the risk of the primary outcome in the subgroup treated with dialysis at baseline. So when we treat our patients now, we treat it because of cardiovascular risk, not because of the renal outcome. So this takes us to the group with on dialysis, and the statements are: in adults with dialysis-dependent CKD, we suggest that statins or statin-ezetimibe combination not be initiated, and this is graded as 2A. And in patients already receiving statins or statin-ezetimibe combination at the time of dialysis initiation, we suggest that these patients be continued, because these patients were included in the SHARP study, and before they reached to the stage of dialysis, they did show a benefit. So when they reached to the dialysis stage, they found no reason to stop statins. And this, and of course, the evidence for this is these studies, which is a 4D study, that utilized atorvastatin 20 milligrams, and the Aurora study utilizing rosuvastatin 10 milligrams. And actually, in these studies, there was no change in the composite, no difference in the composite endpoints at the end of the study period. Now, finally, we come to our target populations, which are the transplant patients. And the statement for the transplant patients for pharmacological cholesterol-lowering in adults is that in adult kidney transplant recipients, we suggest treatment with a statin, and this is graded as 2B. Like we said, those patients are CKD patients, and not only that, they are also receiving drugs that are known to affect the lipid profile. And you can see here that corticosteroids, cephalosporin, and sirolimus are all having an impact on the lipid profile. Tacrolimus does not seem to be affecting the lipid profile, and azathioprine, mycophenolate mofetil have no effect. Now, the only study that was done on the transplant population indicated that the risk of future coronary events in kidney transplant recipients is markedly elevated. Data from the placebo arm of the ALLER trial suggests that the rate of cardiovascular death of non-fatal myocardial infarction is approximately 21.5 per thousand patient years. Now, this is the ALLER study. We'll have to talk about it in details because this is the only study that we have, and it comprised more than 2,000 renal transplant patients that were stable for 6 months or more post-transplant. And the age ranged from 30 to 75 years. Total cholesterol ranged from 155 to 271 milligram per deciliter. Mean LDL cholesterol 158 milligram per deciliter. They were all receiving cyclosporin plus prednisone in 81% of the cases, azathioprine in 65% of the cases, and mycophenolate mofetil in 16% of the cases. 19% had diabetes, and they were randomized to fluvastatin 40 milligrams versus placebo and followed up for 5 years. The mean LDL cholesterol was decreased by 32 milligrams per deciliter, as you can see here. And the results of the other study showed that the composite endpoint of cardiac death, myocardial infarction, and mechanical intervention was reduced, but this was not statistically so, and the cardiac death was statistically reduced. Well, if you look at the other endpoints, you find that the difference was not more statistically significant, and it was thought that maybe because those patients are targeted at a stage after dialysis and transplantation when the damage has already been done. But there was a significantly, statistically significant improvement in the cardiac death and myocardial infarction. And in an unblinded study, that extension study, it showed a definite improvement in the composite endpoint, the primary endpoint, when it was extended for 6.7 years. So these statins usually are really active in this patient population, and the benefits are consistent with the effects of statins in the general population, and it's beneficial in patients with functioning kidney transplant. But because of the nominal lack of statistical significance in the primary analysis, and because of the existence of a single randomized trial, the recommendation is weak. So the recommendation is to treat all adult kidney transplant recipients. And you know that end-stage renal disease treated by kidney transplantation is a chronic disease, and these patients are expected to have deterioration or increase in the risk of cardiovascular events even if they have optimal kidney function. So the recommendation is to treat. But for younger patients less than 30 years, and those who are not included in the LR trial, and if they don't have traditional cardiovascular risk factors, they could choose, the patient chooses not to receive the statins if the patient places more value on, avoidance of toxicity of polypharmacy, and places less value on the possible small reduction in cardiovascular risk. Now for the dosage recommendation in general, you know that CKD patients are at increased risk for medication-related adverse events because of reduced renal excretion, frequent polypharmacy, and high prevalence of comorbidity. Therefore, prescription of statins in people with GFR less than 60 milliliters per minute or in renal replacement therapy should be based on regimens and doses that have been shown to be beneficial in randomized trials done specifically in this population. As you can see here, you are adjusting the dose of statins depending on the GFR, not depending on the LDL cholesterol. Baseline levels of transaminases should be measured before initiating statin therapy, but follow-up with liver enzymes or creatine kinase is not required in asymptomatic patients. Fibrates should not be used concomitantly with statins. Statins should be prescribed in preference to fibrates if you have to make a choice between both. And certain medications like cyclosporin, for instance, in grapefruit juice, increase the blood level of statins. So these are the recommended levels for fluvastatin 90 milligrams, which has to be reduced to 40 if the patient is using cyclosporin, atorvastatin 20 milligrams, simvastatin is in 20-10, and rosuvastatin 10 milligrams, which has to be reduced to 5 milligrams if the patient is receiving cyclosporin. Now this is the last statement on triglyceride-lowering treatment in adults, and it says that in adults with CKD, including those treated with chronic dialysis or kidney transplantation and hypertriglyceridemia, we suggest that therapeutic lifestyle changes be advised, and this is graded as 2D. Therapeutic lifestyle modifications like dietary modifications, weight reduction, increased physical activity, reducing alcohol intake, and treatment of hyperglycemia if present. There is no evidence that it does work, but since it has no harm and since it improves the general condition of the patient, it is indicated when triglycerides reach 500 milligrams per deciliter. We only, or the guidelines indicate the use of medications only when triglycerides reach more than 1,000 milligrams per deciliter, and fibric acid derivatives should be dose adjusted according to kidney function. All the doses are adjusted according to the GFR. Any of the alternatives can be used, and concomitant therapy with statins is not recommended like we mentioned. Nicotinic acid is not recommended with advanced CKD given the risk of toxicity, and this is some of the daily doses of fibrates that needs to be adjusted depending on the GFR. So in conclusion, Mr. Chairman, in treatment of dyslipidemia in CKD patients, we have first to rule out remediable causes of secondary dyslipidemia, then if they're excluded, decision to treat with statin will depend only on the cardiovascular risk. We have to select the dose, and we have to treat according to fire and forget strategy. So if the patient is in the pre-dialysis era, and if the patient has more than 50 years, treatment is recommended. If the patient is 18 to 49 years, treatment is suggested in the presence of a risk factor. If the patient is on dialysis, don't initiate treatment. But you can continue if the patient is already receiving the treatment. If the patient had a transplant, treatment is suggested, and you have to have therapeutic lifestyle changes for hypertriglyceridemia. Thank you.
Thank you very much.